স্যার শুরু করতে পারেন স্যার।
Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 25th lecture of this series. Today will be the case studies on ECG. Our first speaker will be Professor Dr. Abdul Kader and second speaker will be Dr. Rafique Ahmed, sir. As usual, we have got number of faculties with us, including our course directors, Professor Abdul Wadud Chowdhury, sir, and Professor Atahar Ali. We have got Professor Hafizullah Hasan, sir, Professor M.J. Azam, Dr. Khandukar, Zaman, and a number of other faculties. At the beginning of the session, may I request Professor Abdul Wadud Chowdhury, sir, to say a few words about today's topics. Wadud, sir, please. Wadud, sir, please unmute yourself. Okay.
Good evening, everybody, and assalamu alaikum. This is going to be the first program of 2021. And actually, this is a continuation of our original series that will be continued till the mid of this year. Then we'll be starting a new cycle. And this time, we are mainly focusing on case-based discussion, real-life discussions, along with some theoretical tidbit as well. And the explanation, the sharing of experience and wisdom from our senior faculties. Professor Abdul Kader Akun is the professor and head of the Department of Sir Solimullah Medical College and Mitford Hospital. He is a genuine educationist. He likes to teach. Though he is very humble and tried to belittle himself, actually he is not. And he is always very thorough in all his presentations. So I do think we'll be getting some pearls of wisdom and also some fantastic ECGs from Professor Abdul Kader Akun. Sir, the field is open for you.
Thank you, Professor Chowdhury. স্ক্রিন শেয়ারিং আমি এখন শুরু করতে একটু সময় লেগে যায় কিনা দেখি, অনেকদিন পর।
স্যার প্রেজেন্টেশন ওপেন করা আছে ডেস্কটপে?
হ্যাঁ, ডেস্কটপে প্রেজেন্টেশন ওপেন করা আছে।
আপনার নিচে গিয়ে শেয়ার স্ক্রিনে চাপ
স্ক্রিন শেয়ারিংটাই পাচ্ছি না আর কি।
নিচের দিকে দেখেন স্যার,
একটু স্ক্রল করে উপরে উঠাও, ওই যে কার্সর দিয়ে ধরে
আপনার স্ক্রিনের নিচের দিকে গ্রিন কালারের।
হ্যাঁ, সেটাই চলে আসে, কিন্তু আনফরচুনেট পার্ট হচ্ছে যে আমি
ক্লিক করলে আবার একটু ইয়া করা যাবে।
একটু একটা মিনিট একটু কষ্ট দিয়ে দেখি,
কোনো সমস্যা নাই। লোয়ার মার্জিনটা একটু উপরে উঠে দেখো।
চলে আসে। আজকে একটু অনেকদিন পর জয়েন করছি, ভুলেই গেছি মনে হয়। স্ক্রিন শেয়ার
তোমার মেইন স্ক্রিনে নিচে
মনে হয়
দিকে
আসছে।
হ্যাঁ,
এখন কি দেখা যায়?
হ্যাঁ 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 দেখা যাচ্ছে। বাহ,
হ্যাঁ
দেখা যায় কি?
জি স্যার, ঠিক আছে।
হ্যাঁ দেখা যাচ্ছে কাতে। হ্যাঁ,
আচ্ছা,
Excellent.
So, New Year's greetings. It is my immense pleasure for me to take opportunity to talk on ECG in front of the masters of ECGs and also the dedicated learners. So I will introduce the ECG tracing to the masters of ECG so that I can learn something from that. Today I feel some feeling was in my mind that we changed the total scenario of the cardiology department of Sir Solimullah Medical College and Mitford Hospital by introducing the syringe pump in the treatment of the thrombolytics, adding 2 modern ventilators in CCU, ECG monitors in all beds of the CCU with central monitor, 11 monitor in post CCU, 1 monitor in front of the entry point of our hospital gate, cardiology department. Besides, we also introduced 3 echocardiography machine, one of which is the latest model. Besides, we have introduced one more cath lab in the department. These are very difficult job, I thought, but today, when I was preparing to present the ECG, I tried to recapitulate after entry my MD cardiology in 90, for last 3 decades, I am trying to learn ECG, but today I failed. I know nothing in ECG. It is very important. I don't understand ECG. So today I selected only 2 ECG tracing case presentation, considering the examination session in this time. Because during examination, the emergency management gets the maximum priority. Because if a person failed to understand the emergency and manage the emergency patient, passing the examination is difficult. Because the emergency management should be from the background knowledge. But stable patient management, elective management is not that. You can go through the text, you can go through the literature, you can discuss with your colleagues. So we can manage the patient accordingly. So today I am presenting one ECG tracing of a 48 years male patient, smoker, hypertensive, presented with severe chest pain and sweating. And the attendant noticed that patient developed some sort of change of conscious level with cold extremities during transferring from the emergency department to the cardiology department. This is the scenario of Mitford Hospital, because we have the emergency department in the ground stair where all patients attend there. When they suspect the patient has got some cardiac ailment, they refer the patient to cardiology department, and in the cardiology department we do the ECG, like the old NICVD, which we observed in our early part of the cardiology career. So this is the ECG of that patient when he presented in the department. Is there any student to tell me the diagnosis of this ECG? Any students can tell me the diagnosis of ECG?
Kader, you can have a poll, ABC. Do you have A, B, C, D option?
So the diagnosis is wide complex tachycardia. It may be ventricular tachycardia or supraventricular tachycardia with aberrant conduction. So in this ECG, I will ask the student few basic questions. Can anyone tell me what are the site of origin of this ventricular tachycardia? I will tell few sentences and you will choose the points. Number 1 is the distal to the bundle of his bifurcation, ventricular muscle. Both of these and none of these. Which one will be correct answer?
Review.
Yes,
Hello,
sir.
Review. Achha,
Yes,
Review.
sir.
You can just
Anyone is taking
you
part
can just show
in this
A and B.
competition?
A and B, Kader.
A and B.
A
A is the distal to the bifurcation of the bundle of his ventricular muscles, both or none. C is both and D is none. So, Review, can you collect the answer?
The poll is going on. We can see the answer after we end the poll.
Achha,
After
the-
ending of the poll.
Firoze,
So
ask the
another
participant.
question I will put in front.
Firoze,
is
ask
that-
the participant to answer.
Yes, for the participants.
Yes, Kader, you can see the answer.
So the A is 33%, B 33%, C 33%, and D 0%. So I think they answered the right thing, because the next question is, what is the mechanism of the development of the ventricular tachycardia? It is by the enhanced automaticity, A. B is by the re-entry C is the both and D is the none.
We will set the poll again.
Again poll.
A, re-entry. B, increased automaticity. C, both. D, none. And please answer the questions.
আচ্ছা, Firoze, ask the
Boring
participant.
হয়ে যাচ্ছে মনে হয় না?
No, 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 no.
নববর্ষে এটা একটা আসলে boring because I have nothing to present.
আচ্ছা, কাদের?
20% answered that enhanced automaticity, 40% answered the re-entry phenomenon, and C answered by 40%. So answer is both. The enhanced automaticity and re-entry is the basic mechanism of the development of the. Next question is, what is the diagnostic hallmark of ventricular tachycardia? Capture beat, fusion beat, concordance, discordance, or none?
আচ্ছা, A, B, C, D.
A, B, C. A হচ্ছে capture beat, fusion beat. B, concordance. C, discordance. 4, none.
Dear participants, you can answer. You can see the ECG and can answer. আচ্ছা, কাদের?
আমি আসলে কম্পিউটারের কাজ ভালো জানলাম, এখানে একটা করে স্লাইড ফেলাই দিতে পারতাম, বাট
না, অসুবিধা নাই। আমার মনে হয় যে তোমার এই ইসিটা আবার শুরুর কোশ্চেন থেকে ডিসকাশন করতে হবে।
হ্যাঁ হ্যাঁ, সেটাই আমি জাস্ট একটা করে ইয়ে করছি, so that the discussion will take place on that. So answer 63 is the capture beat, fusion beat, 25% concordance, discordance 13%, and 0% হচ্ছে none. Okay. Another question last on this ECG is the treatment option of this patient: pharmacological conversion, synchronized DC shock, asynchronized DC shock, or synchronized AC shock. The patient is in shock. This patient is in shock because pulse and BP is not recordable.
Then review again A, B, C, D.
A, pharmacologic conversion. B, synchronized DC conversion. C, asynchronized DC shock. And 4, synchronized AC shock.
B, 77% B.
77% B. So we can skip
Synchronized DC shock, na?
synchronized DC shock B. So I think
আচ্ছা, মানে any more questions on this ECG? কাদের?
now there are
No,
any
কাদের?
other questions. So
No.
ECG,
কাদের?
it is the most important part. I will ask the faculty, especially Rafique sir, Atahar bhai, or Wadud Chowdhury, and others as well. Chowdhury bhai also. How we can make the diagnosis of ventricular tachycardia on ECG. Because even with all evidence, it may not be able to reach the diagnosis of ventricular tachycardia. We cannot differentiate ventricular tachycardia and supraventricular tachycardia with aberrant conduction. The most important part, that is the diagnostic hallmark, is the capture beat and or fusion beat. But unfortunately, these are not the common finding in ventricular tachycardia. That's why this finding is not found in many of the cases. So, Atahar bhai, একটু আপনি
ডক্টর কাদের,
এখানে ইলাবোরেট করেন
ডক্টর
যে
কাদের,
what are the points by which we can differentiate the supraventricular tachycardia with aberrant conduction and ventricular
আচ্ছা
tachycardia
ডক্টর কাদের,
by ECG.
না রিয়েলি This is the wide complex tachycardia, and there are, as per your explanation, there are some of the points in favor of the ventricular tachycardia. But one point I want to, finally, Rafique sir will comment on this ECG. I will wait for the last comment from the Rafique sir. But before that, one of my observation, there is slight irregularity of the RR complex. Professor Wadud, whether this in favor of the VT or not, there is a slight irregularity of the RR complex.
Actually, VT can have slight irregularity, but the other things, particularly also heavy dissociation, capture beat, fission beat, the axis, the width of the complex, the initial QRS complex, all these things we should take into account. And even after that, sometimes we'll be fooled. And here, look at that AVR. It's positive complex in AVR. Look at V1. This is LPPP morphology. All the complexes are pointing downwards from V1 to V6. There is concordance. These two critical points suggest that this is most likely VT. And the width of the complexes, look at that. It's about 1, 2, 3, 4, I think around 150 millisecond. I'm not very sure.
174 milliseconds. It's written in the upper part, 174 milliseconds.
Per millisecond. So this is very wide. These are very likely to be VT. And whether we have AV dissociation or not, that's another point. And in AVR, the second complex and the 1, 2, 3, 4, 5, 6, between 6 and 7 complex, there seems to be P wave, which is not present in every other bit. So there's likely to be AV dissociated. And all this points to diagnosis of VT.
Sir, now my question to Rafique sir. Sir, because of the irregularity, that is slightly irregularity of the RR interval, whether we should consider WPW as the differential diagnosis, that is WPW with atrial fibrillation. Can you consider this differential diagnosis, sir?
Okay, so the question is, it's a wide QRS tachycardia. To answer your question, if it was WPW syndrome, you will see much more irregularity, number one. Number two, you will also see difference in QRS width, which is not present here. The hallmark of WPW with AFib is irregular RR with irregular QRS duration. It's absent here. But as Wadud pointed out, these are more or less concordant from V1 to V6. A left bundle morphology with QRS of 174 millisecond. QRS more than 160 with left bundle supports VT. And Wadud is right, in AVR, you can see, it's definitely, if you challenge me, I cannot confirm, but maybe there is a P wave after the 7th beat, 1, 2. Yes, after the 7th beat, there is a P wave.
Right,
so all this points to us, and of course, the patient's clinical scenario is very much supportive of ventricular tachycardia.
Sir, in the examination or in front of the student,
Yes.
actually, this is the objective of Professor Kader showing this ECG. Whether the student will tell the only one answer or they will put the differential diagnosis.
Okay, this is the way American Board of Internal Medicine gives questions, ECG questions. They send to non-academic cardiologists in practice. If 5 of them answers correctly, everybody, they will usually send it to 5 to 10 people, doctors. And if all of them answers correctly, then that will be put in the exam. Question would be, in Bangladesh, we need to use the same thing, that if we give this ECG, is it conclusively a diagnosis? We should not give overlapping choice in exam. I mean, if I'm asking question, I will ask, is it VT? Or do you think it is SVT with aberration? Or as you said, atrial fibrillation with left bundle branch block? Those are the valid choices. And my answer will be ventricular tachycardia, unless proven otherwise.
So, Professor Kader,
Right, it is basically it's a case of ventricular tachycardia with left bundle branch block morphology. So for the students, by this presence of the left bundle branch morphology or right bundle branch morphology, we can predict its origin. Can anyone tell me if it is left bundle branch block pattern, from which ventricle it is coming?
actually, it was the answer was in your second poll. That is the possibly the answer was the from the Kader, this second poll.
Right. So we can proceed with this ECG. So ECG diagnosis হয়ে গেল যে ventricular tachycardia by considering all this point, that is the white complex. It is basically we diagnose it as white complex tachycardia, most likely ventricular tachycardia, as the RR interval has got some irregularities. If the RR interval is pinpointed regular, then we can make the diagnosis of supraventricular tachycardia with aberrant conduction. This is one of the important points by which we can differentiate.
Now, Professor
Besides
Kader,
the duration of the QRS complex, if it is more than 140 milliseconds, that favors the diagnosis of ventricular tachycardia. Concordance pattern.
Kader, we have got another examiner, that is Professor Abdul Wadud Chowdhury. Wadud bhai, do you want to get answer from the student left versus right, apical versus basal part? Actually, this was the second question of Professor Kader.
Actually, the most important thing with this ECG, what we suggest, how are you going to manage this case? How will be the presentation?
Right.
That's the most important thing. Whether they recognize it as a VT, which is a very dangerous arrhythmia, with life-threatening arrhythmia, whether they can promptly decide about the way of treatment and what short questions, history, they would be asking. These are the three things that actually ask. Because the history is important in some aspect. If the patient is a previously normotensive non-diabetic patient who has severe vomiting or gastroenteritis and then developing this, I would be suggesting that the patient should be seroconverted and immediately the electrolyte should be checked, either by blood pressure analysis or by proper serum electrolyte, so that there is likely to be electrolyte disturbance that has led to this. If the patient has history of MI, then this is basically like a scar-related VT. So the patient is likely to have LV dysfunction, and after conversion, we should be paying attention to that. These are the important things. Or the patient is coming with a history of delivering a baby 1 week before, then coming with this, then the patient have peripartum cardiomyopathy or something like that. And that patient should not have this sort of VT unless there is underlying condition, long QT or something like that. These are the underlying things that I want to ask the students whether they can think about these things.
Sir, Rafique sir, actually how to analyze the origin of the VT, sir, for our academic purpose?
Well, I mean, listen, we have to make it very simple. We cannot ask very complex questions. One would be, is it coming from the right side or left side? If the VT morphology is right bundle branch type, it is coming from the left ventricle. If it is left bundle branch block type, it is coming from the right ventricle. If it is negative in 2-3 AVF, it is coming from inferior surface. And this is what it is. At best, I can ask in this question that it is coming from the right ventricle and it is coming from the inferior. But also, if you look at lead V6, it's negative. So it's coming from the apical part of the inferior. And that is, I mean, this kind of discussion is good for academic interest, but I don't think beyond coming from right and left ventricle, we should burden the trainees unless they are electrophysiology students.
Thank you, Kader.
That is true, sir. I think that is the most important, is right side or left side origin. That is important. So with this, we can go how this patient was managed. So in the emergent, in the CCU, the patient had electric cardioversion electric cardioversion. This is the ECG after electric cardioversion. So what is the diagnosis of this ECG?
You have to give choices.
Again, Kader, A, B, C, D.
It is acute STEMI anteroseptal.
A,
With
anteroseptal, right.
Anteroseptal, acute ST elevated MI. Another is it may be non-ST elevated MI.
You can give only 2 or 3 options, no problem.
Another is actually this ECG is difficult to make the diagnosis other than ST elevated MI because there is very clean cut ST elevation in V1 and V2. It may be Prince metal angina, that may be another option, but ECG, the diagnosis.
Can I say something, sir?
হ্যাঁ অদূত বলো তুমি এটার কি কি ডিফারেনশিয়াল ডায়াগনোসিস ইসিজি তে করবা
Most important thing is that there is ST elevation in V1 to V3, V3, and there is depression in the inferior list opposite to the anterior surface.
inferior lead.
To that, this is nothing most unlikely to be anything else other than acute anteroseptal MI.
Yes.
What about 1 and AVL?
There is mild ST elevation in lead 1 and also in AVL.
100%, Kader.
Ji?
Actually, 100% poll in favor of your answer. That is the intro MI, that is acute intro MI. Sir,
Okay.
sir, my question to Rafique sir. Sometimes you see this is the by ECG, this is the extensive intro-wall myocardial infarction, and the culprit vessel is the LED, and site of lesion should be the proximal. But sometimes we see there is no RBB. Is there any explanation, sir? We are expecting RBB here, but there is no RBB.
Why are you expecting RBB?
Now, in this ECG, sir?
No. I mean, this is, as you said, it's probably extrinsic anterior. I mean, I would consider it anterolateral unless Hafiz have any other comment because there is ST elevation in 1 and AVL also. Hafiz? Hafiz, okay. Yeah. So what did you find? Did you do angiogram on this patient?
Kader?
Right. Actually, for the students, the diagnosis of extensive anteromyocardial infarction, ST elevated extensive anteromyocardial infarction, usually we consider the ST segment elevation from V1 to V5 at least, along with ST elevation in lead 1 and AVL. So in this ECG, the straightforward ST elevation in lead V1, V2, and some ST elevation in V3, and mild ST elevation in lead 1 and AVL. So this is a diagnostic dilemma because there is no involvement of the V4 and V5, but there is involvement of the lead 1 and lead 2. That can be explained by the large diagonal branches being involved after the first septal perforator. The LED is being occluded after first septal perforator that occluded the relatively larger diagonal branch. It may be a diagonal 2 even. Sometimes the diagonal 2 is larger than diagonal 1. Not always similar. So that involvement might explain these changes. The distal to the first septal perforator involving the LED after septal perforator. So that's why there is a ST elevation in V1 to V3 and involvement of that diagonal branch distal to that stenosis. So it produced some ST elevation in lead 1 and AVL, but there is no significant ST elevation in V5, V6.
Firoze, you did give the lecture on localization. Do you want to comment?
No, sir. The ST elevation in V1 indicates it is most likely in the proximal LED, and the Also, 1 and AVL indicates it is proximal to the diagonal 1, the first diagonal. But this is the, if we think it as a single lesion for it, but there may be multi-site lesion, that is LED and LCX lesion. The non-elevation of ST, non-involvement of the V4 and V5, V6, I cannot explain that one.
Okay, so let me tell you that how the EKG board defines this. This is not extensive anterior because V5, V6 is missing. And then lead 1 AVL, you can explain from the diagonal involvement. But I would request you not to go too much into the EKG. There are 2 reasons I tell the fellows. One, you need to pass the board, and then you need to also take care of the patient. For taking care of the patients, don't stretch too much about what you're going to find. And I would caution you not to look for a second culprit. A second culprit is unusual, very unusual in a STEMI situation, second culprit. Because I tell this, God is not that unkind to give you 2 culprit lesions, but it can happen. Richard Conti from clinical cardiology, he has shown cases, and we have a bunch where there are 2 culprits, but usually there is 1 culprit. So 1 culprit, and the EKG does not ask you to define the vessel. EKG asks you to define the territory, which is good for the board purposes. So I would stop there and then think about, what's the next in terms of management. And then I will come back to the electrophysiologist, which I'll probably invite the discussion later.
So, Hafiz bhai, your answer is very, very important, because if we spend more time, it will delay the treatment option of this patient. But in this ECG, as there is depression in inferior lead, in the past, it was considered as the reciprocal change, and it is not significant at all. But it gives us the idea, probably the patient has got some stenotic lesion, that is significant stenotic lesion, either in the right coronary artery or circumflex artery, and probably that patient is getting collateral from LAD. That is possible. But when there is ST elevated MI, that means the patient has got thrombus formation in LAD territory. And in most of the cases, the stenotic lesion is moderate, not very severe. ST elevated MI in severe stenotic lesion is relatively uncommon. So there might be some stenosis, like 60% stenosis in the LAD, and there is total occlusion of the artery by the thrombus formation. So that stops the collateral circulation to the LCX or RCA, that produce the ST segment depression in inferior leads. So for the students, they should guess that the patient is probably having 2 lesions in this situation, but this is a suitable case for primary PCI, because the patient presented very timely, VT was converted to sinus rhythm, and this is the time to take the patient to cath lab to do the primary PCI. In that situation, if there is an stenosis in the right coronary artery, we can go for the stage procedure. So we will go to the cath lab with this patient if the facility is available.
Kader bhai, আমার একটা কথা, general advice. Anybody going into the case, doing the angiogram, like fellows have this tendency, and I'm sure there are fellows in this group. Do not go to a case unless you know the patient and you have not seen the EKG. So if the fellow comes to the case without knowing the patient and without looking at the EKG, even in primary, I tell them scrub out, look at the EKG and come back. And this is very important. I'm very particular about that. Second, right, because after the angiogram, you need to think about the EKG and the presentation. What is the best fit and how you can explain.
Right.
So things will unravel more after the angiogram. And I have another rule book. Many of my partners, they do 1 angiogram, like the inferior ST elevation, they look at the right and they start doing the PCI on the right, which I disagree. politely, because I think we should do the diagnostic angiogram first. Think about this. It takes nanosecond. Even if you're doing primary, you can tell the staff, get ready, start the preparation of the gizmo, TUI and all that. In the meantime, you quickly look at the total angiogram, left and right, and then decide.
Right.
Thinking is allowed in the cath lab. We are not monkeys there.
Yeah, that's true. Any comment from other faculties?
স্যার আমি একটু বলতে পারি স্যার?
You are always welcome, Azam.
মানে আমাদের আসলে HTMI আমাদের যে অ্যাড্রেস করার যে ইস্যুটা সেটা আসলে প্রথম হচ্ছে হুইচ ওয়ান ইজ কালপ্রিট। আমাদের বিশেষ করে ইনফ্লুএমআই সেটিং এ আমাদের মানে ডিটেকশনটা এতটা কমপ্লিকেটেড না যেটা ST এলিভেশন এন্টার সেটিং এ যেটা হয়। আমাদের এলইডি আমাদের কোনো সন্দেহ নাই, ডায়াগোনাল ইনভলভমেন্ট ফার্স্ট সেপ্টাল নাকি ফার্স্ট সেপ্টালের আগে না ফার্স্ট সেপ্টালের পরে নাকি ফার্স্ট ডায়াগোনালের আগে না ফার্স্ট ডায়াগোনালের পরে, তার সাথে কনকমিটেন্ট আদার ভেসেল যখন ইনভলভমেন্ট থাকে সেটা তখন আমাদের কাছে একটু কনফিউজিং মনে হয়। অনেক সময় টাইপ 4 এলইডি যদি হয় তাহলে অনেক সময় ইনফ্রাএমআই প্রেজেন্টেশন নিয়ে আসতে পারে। আমাদের এখানে যেটা অ্যাড্রেস করার বিষয়, যেটা হাফিজ ভাই রাইটলি বলছে যে এস্টিলেশন এমআই হুইচ ওয়ান ইজ কালপ্রিট, সেকেন্ড কালপ্রিট মোস্ট আনলাইকলি, কিন্তু লিটারেচার দেখা গেছে কখনো কখনো ডাবল কালপ্রিটও থাকতে পারে, স্পেশালি যেটা বললাম টাইপ 4 অ্যালার্জির ক্ষেত্রে হতে পারে। এখানে আমাদেরকে যেটা খোঁজার বিষয় হচ্ছে যে এই যে এই ইসিজিটার ক্ষেত্রে যে আসলে আমাদের তো এলইডি ইনভলভমেন্ট এত কোনো সন্দেহ নেই, এটা কি প্রক্সিমাল না ডিস্টাল সেটা একটা ইম্পর্টেন্ট ইস্যু হতে পারে। আমরা কত তাড়াতাড়ি আমরা ইন্টারভেনশনে যাব। আমরা যদি দেখি যে ডিস্টাল এলইডি অপারেশন যদি হয় কিংবা প্রক্সিমাল যদি এলইডি অপারেশন হয়, V1 V2 V3 যখন থাকবে তার সাথে যদি ইনফেরিয়র লিডে যদি বিশেষ করে 2-3 ABF যদি চেঞ্জ আছে, এটাতে যেমন আছে দেখা যাচ্ছে, তাহলে এটা আমাদের কেসে যেটা মনে হচ্ছে যে ডিস্টাল এলইডি অপারেশন হতে পারে। তার সাথে অন্য আদার কনকমিটেন্ট ভেসেল ইনভলভমেন্ট আছে কিনা, বিশেষ করে এই যে স্যার যেটা বললেন ডায়াগোনাল অথবা L6ও আপনার যদি এখন এটা কি লেফট ডোমিনেন্ট না রাইট ডোমিনেন্ট সেটার উপর ভিত্তি করেও কিন্তু আমরা ডিসিশন নিতে পারি। কিন্তু এই ক্ষেত্রে আমার অ্যাপ্রোচ হবে স্ট্রেট ওয়ে ডায়াগনস্টিক এনজিও যখন আমি করতে যাব, প্রথমে আমি রাইটে একটা ডায়াগনস্টিক ক্যাথেটার দিব, যদি ইফ আই গেট এ ক্লু ফ্রম দিস হিয়ার দেন আই গো ফর স্ট্রেট ওয়ে ডাইরেক্টলি আমি গাইড ক্যাথেটার লেফট গাইড ক্যাথেটার নিয়ে আমি আগাবো। এটা হলো মাই অ্যাপ্রোচ স্যার।
Thank you, Azam. Sir, Kader sir, we can proceed to the next part of the lecture.
Okay, so for the student, I asked the question, this is the answer. The VT arises from the distal to the bifurcation of the his bundle in specialized conduction system, or it can arise from the ventricular muscle. And sometimes the ventricular tachycardia might arise by the combined tissues, both the tissue types. And the mechanism of the VT is the disorder of the impulse formation or disorder of the impulse conduction. These are the two pathophysiologic mechanisms by which the ventricular tachycardia occurs. And this impulse formation disorder is the enhanced automaticity or triggered activity. And disorder of the conduction is the re-entry phenomenon. This mechanism is very important because when you will go for the electric cardioversion, it works in case of re-entry, but in case of automaticity or triggered activity, the cardioversion may not be effective at all. So ventricular tachycardia can be hemodynamically unstable, causing severe hypotension and can thus be life-threatening. And ventricular fibrillation, asystole, and sudden cardiac death, these three consequences can occur soon after the ventricular tachycardia if the action is not taken immediately. And sustained ventricular tachycardia that I asked, that lasts for more than 30 seconds or is symptomatic. And non-sustained ventricular tachycardia, this is the very simple thing most of you know, but I am going to recapitulate the students regarding this non-sustained ventricular tachycardia that lasts for less than 30 seconds and is asymptomatic. So ventricular tachycardia may be monomorphic or polymorphic, all of you know about that. And QRS morphology of the ventricular tachycardia may be either right bundle branch block pattern or left bundle branch block morphology by which we can predict the origin of the ventricular tachycardia that Rafique sir already clarified. But sometimes this ventricular tachycardia might occurs with QRS morphologies anywhere in between these two sides. So what general rule we follow for the diagnosis of the ventricular tachycardia? This is important for the taking decision in emergency situation. One is if there is any question regarding the diagnosis of the ECG, whether BT or supraventricular tachycardia with aberrant conduction, if we cannot clarify by ECG, then treat the patient as ventricular tachycardia. That is one of the important rules. If the ventricular tachycardia is more likely in patient with ischemic heart disease, if the patient is non-ischemic heart disease or patient has got the systolic congestive heart failure, in that situation, VT is more likely than supraventricular tachycardia with aberrant conduction. This is the clinical situation. And ventricular tachycardia is more likely with advancing age. At least older than 40 years are considered as advancing age. Some studies, they took the 40 years as a landmark for the advancing age for the development of the ventricular tachycardia. So diagnostic dilemma is there. There are different criteria and algorithm for the diagnosis of the ventricular tachycardia and to differentiate it from the supraventricular tachycardia. But there is no single method by which we can confirm the diagnosis. In Brugada criteria, they consider the concordance in the precordial leads and R2S interval if it is greater than 100 milliseconds in any one of the precordial lead that favors ventricular tachycardia. And evidence of atrioventricular dissociation, Professor Wadud Chowdhury discussed very nicely, and examine the morphology of the QRS complex to see if it meets the specific criteria for VT, like RBAB, when there is upright in V1 and left bundle block that is downward complexion in V1. So these are the criteria by which we can diagnose the ventricular tachycardia. Another very important term that may be asked in exam, slow ventricular tachycardia. That is, the ECG morphology and all criteria supports the diagnosis of the ventricular tachycardia, and if the rate is below 100 beats per minute, then it is slow ventricular tachycardia. This is another patient, a 65 years old gentleman, is a diagnosed case of ischemic cardiomyopathy with ejection fraction 22%, admitted with heart failure with NYSA class 3, and blood pressure was 70 by 50 millimeter mercury, and bilateral coarse crepitation. So the patient was on standard heart failure management along with inotrope support. In the hospital course, the patient developed bizarre type of ECG. This is the ECG of that patient. And with this ECG, what could be the diagnosis? From students, it is 3 points I will mention, and you have to make the diagnosis. Number 1, ventricular fibrillation. Number 2, ventricular tachycardia. Number 3, torsades de pointes. Which one will be the answer for this ECG?
Ribu, show us the pool.
ABC.
Started the poll.
A, ventricular fibrillation.
Number
B,
ventricular fibrillation, ventricular tachycardia, and torsades de pointes.
Please participate and answer, please.
So ventricular fibrillation 32%, torsades de pointes 57%, and 7% ventricular tachycardia, and 1%, 4% ওটা নাই আর কি। So Atahar bhai, so opinion differed and most of them diagnosed it as torsad is D point is. তাহলে what should be the diagnosis of this ECG?
So we can invite our faculties to take.
Faculties, right?
Firoze, as Rafique sir will comment lastly, but
Sir,
before that,
we have got Dr. Khaliqujaman with us. Khaliqujaman bhai, what is your diagnosis with this ECG? Khaliqujaman bhai, nine.
Zaman.
Dr. Asad. No. One is there.
Zaman sir is not here, sir.
Okay. Mohsin Hossain bhai. Dr. Mohsin Hossain bhai.
He's here, but it's muted.
So I think we can take the final comment from Rafique sir.
Well, I mean, I know that a lot of people answered torsad. First of all, there is no definite QRS complex that you can identify. Let's look at lead 2. If you look at lead 2, irregular interval, irregular morphology. To call it a torsad, you have to show that this is twisting around the point, and it has to have discrete ventricular activation. So if you look at the lead V1, in the beginning, it looked like there is some organized activity. And if that continued twisting, I would have called it torsad, but it doesn't. If you look at lead 2, it is simple and straightforward ventricular fibrillation, and it is not torsad. The other thing about torsad, that sometimes the definition between torsad and VF is a question of semantics. Mechanistically, they are both same. And if you give a middle strip of this torsad, you can't distinguish between the two. A exam torsad EKG should be which terminates spontaneously so that it makes it the life of our MD students easy. But this is ventricular fibrillation, no question about it.
So this is the ECG of ventricular fibrillation, and ventricular fibrillation shows the chaotic, irregular deflection of varying amplitude, and there is no identifiable P waves, there is no definitely identifiable QRS complex or T waves, and the rates remains between 150 to 500. So these are the points by which we can make the diagnosis of the ventricular fibrillation, and this fits with the ventricular fibrillation. Then the question comes how this ventricular fibrillation arises. The two mechanisms plays role in the development of the ventricular fibrillation. One is the multiple wavelet mechanism, in which there is multiple small wandering wavelets are formed, and the fibrillation is maintained by re-entry circuit formed by some of the wavelets. And another mechanism is the mother rotor mechanism, in which the stable circuit is formed, and this is called the mother rotor, and the mother rotor then gives rise to propagation of unstable daughter wavefront, which results in the chaotic electrical activity seen on ECG. So these are the two mechanisms by which this is formed, and this is the situation where the heart cannot pump out the blood. So if it persists for longer period, ultimately it leads to, and what happened to this patient? What is the treatment of this patient? Should we go for the pharmacological cardioversion or electric cardioversion? If it is electric cardioversion, should we go for the synchronized or asynchronized? So first question, treatment option. A, pharmacologic intervention. B, electric cardioversion. So answer from the gallery.
Can I just add three choices? One, pharmacologic. Two, synchronized DC cardioversion. Three, asynchronized DC
Asynchronized.
cardioversion.
Right.
Yes, three choices.
Synchronized and asynchronized. Right.
Restart the poll because some of the attendees started the.
Okay, sir. I'm restarting the poll again.
So A, pharmacological cardioversion, B,
Synchronized,
DC
C,
cardioversion,
asynchronized.
and C, asynchronized DC cardioversion. So the time is up, sir. 88% says it's asynchronous DC cardioversion, and 12% says it is synchronized cardioversion.
So if anyone answers synchronized, how we can synchronize? So we plan for asynchronized electric cardioversion. This is the ECG of that patient. The fibrillation was controlled to the junctional rhythm, converted to junctional rhythm. Again, but after even repeated cardioversion, ultimately the patient developed this ECG. Straight line, so we could not save this patient. So I will say few words about cardioversion, and I will leave this to Rafique sir for discussion on cardioversion. The cardioversion may be chemical or pharmacologic cardioversion. Another is the electric cardioversion. There are a lot of options there. And here I am correlating the electric potential with ECG. You can see this is the electric potential waveform, and this is the ECG. The ECG from this beginning of the QRS complex to the beginning of the T wave. This is the absolute refractory period when the myocardium or conducting tissue that does not respond to any stimulus, strong, whatever the strength of that. That is the absolute refractory period. Then second option is the effective refractory period that started from the beginning of the QRS complex and ends at the early part of the ascending limb of T wave. So this is called the effective refractory period. So in absolute refractory period does not allow for any depolarization, and effective refractory period may allow for non-propagated depolarization, and relative refractory period lying from the beginning of the T wave to the proximal third of the descending limb of the T wave. This is the relative refractory period when the heart muscle responds to any stimulus that is stronger than the past one. And after the descending limb, proximal distant descending limb of the T wave is the supranormal period of this. This is the vulnerable part. In this situation, they remain hyper-excitable period when even a weak stimulus, definitely adequate stimulus, whatever the strength, adequate stimulus can produce the action potential. So my question to the students, if we give the synchronized DC shock, at which point it will put the shock? At the beginning of the QRS complex, now A hoche beginning of the QRS complex, B tip of the R wave, C at the most deepest part of the S wave, or at the tip of the T wave. So with this 4, please give the answer. So highest answer is tip of the R wave, beginning of the QRS complex 21%. C means the deepest part of the S wave is 4%, and tip of the T wave 29%.
That
Second,
is tip of the R and tip of the T.
tip of the T 29%. So what we should do? Hafiz bhai?
I think
Because synchronized DC shock, if we put the synchronized DC shock, which part we should put? Hafiz bhai কোনো কমেন্ট করবেন কিনা এখানে?
আমার মনে হয় যে he's not in the scene. You just give your finally Rafique sir will final comment, but before that you give your explanation. I think
Explanation is that I will ask Rafique sir as well, because we do not understand many things, because this is the absolute refractory period. Again, this refractory period is divided effective refractory period. This effective refractory period is important for the DC shock, because during this effective refractory period can allow the non-propagated depolarization. That is important. এখানে যদি কোনো propagated impulse আসে, atrium থেকে আসে বা আরো কোনো conduction থেকে আসে, it will not respond. But যদি non propagated, আমরা যে electric shock যেটা দিচ্ছি, that is a non propagated impulse. So that stops the electrical activity momentarily, external stimulus. But if we good, 29% answered at the tip of the T wave, if we give the impulse to the tip of the T wave and descending link of the T wave, that is the most vulnerable part of the ECG. And in that situation, the ventricular tachycardia may turn to ventricular fibrillation. So we will never give any DC shock at the level of the T wave. Usually, the DC shock is given at the tip or proximal third of the descending limb of the R wave. That is the answer. Sir, Rafique sir?
Can you go back to the slide, please? Okay, this is a beautiful slide. When you synchronize, first of all, audience, few answered asynchronous and synchronous. We need to understand what it means. That means when we synchronize to the QRS complex. The machine has no ability to synchronize to T wave because the machine doesn't see that. So when it synchronizes to the QRS complex. So what happens if I give the shock on the QRS complex? It will not capture the ventricle. But let's say I'm doing a cardioversion for atrial fibrillation. It will not capture the ventricle, but it will terminate the atrial fibrillation. So we will not produce ventricle. But if we give any shock during relative refractory period, that is the vulnerable period, you can induce VF. It is not always true that you will induce VF, but you may induce VF. So second, to give synchronized shock, there should be some QRS complex. If we try to do synchronized cardioversion during VF, the device will never give the shock because it will not find any QRS complex. That is the important reason that we give asynchronous, because and so the trick is, if you think it is VF asynchronous, if it is VT or there is discernible QRS complex, give the synchronized shock. Now, let's say you forget to synchronize when there is VT and you develop VF. Do not panic. charge the device, give the next shock asynchronous. The mistake people make that they, by mistake, they can give asynchronous shock. Patient goes into VF and they recognize the mistake, then they put the patient in synchronized. And if you do that, then the device will not shock anymore. So this is a very quick thinking process. If you ever have given a asynchronous shock, patient goes into VF, it can happen to anybody. There is no reason to scream and shout. Be calm, charge the device, give another asynchronous shock, patient will go back into normal sinus rhythm. Thank you. This is a good slide.
Thank you, sir. So, electric DC cardioversion, a transthoracic DC shock of sufficient magnitude, depolarizes the entire myocardium, rendering the entire heart momentarily refractory to repeat depolarization. Therefore, the most rapid entrenching pacemaker, usually the SA node, resumes the control of heart rhythm. Thus, the DC cardioversion defibrillation very effectively terminates tachyarrhythmias that results from the re-entry. However, it is less effective for the terminating tachyarrhythmia that results from the automaticity, because the return rhythm is likely to be the automatic tachyarrhythmia. That's why we should know the mechanism of development of the arrhythmias. The DC shock must be synchronized to the QRS complex called the DC cardioversion, because a shock that falls during the vulnerable period near the peak of the T wave can induce VF. And DC shock applied without synchronization to a QRS complex is DC defibrillation. Its use is ventricular fibrillation, because the synchronization of the shock to the QRS complex is neither necessary nor possible. And another option where we give the shock without synchronization is the pulseless VT. So my question to the faculties, why this VT morphology, pulseless VT, we do not use the synchronized shock? I do not understand why it is so. So I want to know from the faculties why the pulseless VT needs a synchronized DC shock.
No, I will give, if there is any QRS complex and I can synchronize, I will give synchronized shock. If you have confusion between VF and VT and the complexes are very small, then you will give asynchronous, but I will not give asynchronous shock just because it is pulseless VT.
Rafique bhai, I don't understand that the synchronized and non-synchronized is basically whether we are recognizing the QRS complexes. If we cannot recognize the defibrillation, machine cannot recognize. So if you cannot recognize, then it should be the R and the S complex and overwhelm the myocardium with the electrical discharges. If we cannot recognize, then give asynchronized. So I don't think this is a big issue. Because,
no, it's not. Absolutely right, Hafiz. I mean, you made it very point. If the machine can recognize the QRS complex, it should be synchronized shock. It doesn't matter what the patient's clinical condition is.
Right. What happened to our patient? Or are you done with that discussion? Sorry, I missed it. That patient that had a sustained VT and then pulseless and then shocked.
Our patient had
ST elevation.
The second patient was ventricular fibrillation on the background of heart failure.
The first one with the ST elevation, MI in the V1 to V4, and then lead 1 AVL survived?
Yeah. That patient survived and diagnosed as ST elevated MI.
What was the culprit?
Cardioversion.
What was the culprit?
In our facilities, we cannot go for the primary PCI, because only in office hour we can do the primary PCI in Mitford.
So how did you manage?
We managed it by thrombolytic agent.
And echo is done?
Echo was done later and showed septal wall hypokinesia. because the
This is
duration
tough,
of
but
the patient was, the result was good. The patient's result was good with thrombolytic therapy because the early normalization was there, the relief of chest pain, and also there was early peaking of the enzymes. Every evidence were in favor of effective thrombolysis.
Thank you, sir. I think we can proceed, sir.
And so DC electric cardioversion or defibrillation can be delivered as one is the monomorphic current, that current travels in one direction between the two electrodes, and another is the biphasic current. The current reverse direction part way through the shock waveform. The biphasic device requires lower energy and has been shown to lead to higher rates of return of spontaneous circulation. So, however, the survival outcome are similar in both devices. And analysis the complication of the DC cardioversion is acceptable because complications are usually minor and includes the atrial and ventricular premature beats and muscle soreness. And less commonly, multiple shock can induce myocyte damage and electromechanical dissociation, and sometimes the patient might develop pulmonary edema. And contraindication of the DC shock is digitalis toxicity associated tachyarrhythmia, and if the patient has got the hypokalemia. Presence of atrial thrombus, sinus tachycardia, and catecholamine induced tachycardia, and multifocal atrial tachycardia. In this situation, we have to avoid the DC shock. So with these few words, thank you everyone for participation.
Kader, thank you very much. Actually, I want to take some comment from Rafique sir about the contraindication, sir. The contraindication mentioned by Kader in the last slide.
If somebody has VF,
There is
and
no-
there is no contraindication for cardiovascular defibrillation because otherwise the patient is going to die. So these are relative issues. I mean, digitalis toxicity, somebody has atrial fibrillation, or somebody has atrial thrombus, somebody has atrial fibrillation. I'm not going to go for cardioversion. Sinus tachycardia, of course, is the con. Now, let's say catecholaminergic ventricular tachycardia, and you have tried everything else, and patient is hypotensive, blood pressure is 60/30. Of course, we will have to cardioversion. So these are the things that we have to keep in mind when we do the cardioversion. But of course, in the situation of VF or hemodynamic unstable VT, we have to do this. Even let's say in the setting of hypokalemia, potassium is 2.8, patient goes into ventricular fibrillation. What am I going to do? I have to defibrillate the patient. So, but these are important points to remember.
Thank you, sir. Thank you, Professor Abdul Kader Akand, sir, for your nice presentation. I think we can move on to our next session. This session is Dr. Rafique Ahmed, sir, will show us some ECG.
Can I point out something because I think it's important to mention about the cardioversion. So there is something called the elective cardioversion, we call. That means that patient has atrial fibrillation and we are doing cardioversion electively. And there is cardioversion like DC shock. So what the terminology is different because it's the same thing, but I'm just telling you, Kader bhai, that the way we call the cardioversion here. So DC shock, that means patient has emergency catastrophe and shock, DC shock was given. And then you can find out what they did. But cardioversion is usually we use the term here in the US as cardioversion from a rhythm, planned cardioversion, elective cardioversion, or emergency cardioversion because of the uncontrolled atrial fibrillation in the emergency room. And when we do shock for the VF VT, pulseless VT, then we use the term shock. And I think it is important to for the physicians in treating this, that what this cardioversion used for, and therefore we can anticipate the complications. For example, post-CABG, VF arrest, MI, VF arrest version, you can have cardiac stunning and then mechanical complications with pulmonary edema, as you mentioned. And you can have same thing with atrial fibrillation. If the EF is bad, or the elderly patient, elective cardioversion, you may have sinus pause, sinus arrest. You can have significant bradycardia. Patient may decompensate. Anesthesia can give you LV dysfunction and further problem. So when we talk about the cardioversion, we need to think about, and the contraindication is relative contraindications and absolute contraindication in the case of elective cardioversion. I will divide these that way, not like the whole cardioversion as one big heading. I will go for subheading and understand that which setting, when we are using these cardioversion procedures.
Actually, in this
And
contraindication of the cardioversion is based on for the patient of atrial fibrillation, because the atrial fibrillation is the most common arrhythmia in cardiology practice. Atrial fibrillation is the most common arrhythmia. And another, Rafique sir will tell me the statistics. I cannot say the real picture of that atrial fibrillation that needs the emergency cardioversion, and sometimes we go for elective cardioversion. But in our practical life, in our situation, the most of the atrial fibrillation is related to the valvular heart disease, especially the mitral valve disease. So in this situation, we do not consider the cardioversion. We just control the ventricular rate, either by beta blocker, digoxin, etc. So, Rafique sir, can you tell me how frequently you are doing cardioversion in atrial fibrillation, elective or emergency?
Well, emergency electrical cardioversion for atrial fibrillation is very rare. But the main concern is that you don't know if the patient has a blood clot or not. So we definitely try to avoid it. Cardioversion. Only situation will be if the patient is really hemodynamic unstable, you cannot control the rate. In that situation, you may do it, but it is, I don't remember last time that I did one. So it is very rare. And I'll be very, very careful about it because of the risk of stroke.
Another question, sir. In case of digitalis we are using in valvular heart disease, we are using in heart failure patient. Yes. These two are the main concern, and in certain situation of the ischemic heart disease with atrial fibrillation, sometimes we prefer beta blocker, but sometimes we can use digitalis. How frequently the digitalis toxicity produces ventricular fibrillation?
I have not seen
because
any.
In the textbook,
yes,
it clearly written that digitalis toxicity is ventricular fibrillation. We don't care for any underlying cause. We will go for the electric cardioversion. There is no shadow of doubt. We will go for that. But in text and almost all literature, first they told that the digitalis toxicity is a contraindication. And in some text, it mentioned that it is absolute contraindication. So my question came in mind, but I could not find out the answer. Does digitalis produces ventricular fibrillation? That question came to my mind.
Oh, yes. Digitalis can cause after depolarization. And that's why it can actually produce, theoretically, it can produce ventricular arrhythmia. Most of the time it is atrial arrhythmia. But the question would be, let's say somebody is digitalis toxic, and I'm planning to do electrical cardioversion electively. I'm not going to do that. Yeah. I have to wait until the digoxin level comes back to normal, then only do the cardioversion. No question about that. And you're absolutely right. I mean, that has to be kept in mind, that we remember these scenarios.
In the ACLS, there is no separate thing that I have seen with the ventricular fibrillation. The digoxin has a separate paragraph. I think in the VF, we'll have to treat VF as VF. And then if it is a refractory situation, then you need to go to the differential. But I need to clarify one thing. The emergency electric cardioversion for AFib versus cardioversion in the emergency room are two different things in the US. Emergency room physicians are doing cardioversion in the emergency room for atrial fibrillation and then sending them home. We can talk about that strategy, but I would request that before we do any urgent electric cardioversion for AFib, we really need to evaluate the patient first, that what is the underlying issues, what are the common causes of AFib, do we have a transthoracic echo, do we know whether the patient is on DIG or patient has thyrotoxicosis. All these are important basics. And in the US, there is a practice called the cardioversion in the emergency room. That is not emergency cardioversion. Rafique bhai, do you have any comment on that?
No, you made it point. I think let's move on because the time is getting late.
রফিক স্যার আমার একটা কোয়ারি ছিল আর কি স্যার, আপনি যদি বলেন।
Sure.
এটা হচ্ছে আমরা যেটা পড়েছি, আমি এখনো পাইনি, অনেকদিন ধরে খুঁজছি যে digitalist toxicity can cause all sorts of arrhythmia except Mobius type 2 heart block. আমি এটা এক্সপ্লেনেশনটা দিতে পারছি না, আমাকে যদি একটু বলতেন তাহলে আমার জন্য হেল্প হতো।
I don't know. I have no answer for that.
স্যার স্যার আপনার কাছে এটা থাকলো, আপনি যদি কখনো ওটা, আমি খুঁজে বুঝতেছি না আর কি, আমি চেষ্টা করছি।
Sure.
যদি স্যার পান তাহলে আমাকে একটু টেক্সট করলে হবে স্যার। থ্যাংক ইউ স্যার।
Sure. Okay. So shall we do this, Firoze?
Yes, sir.
Yeah.
Go ahead.
So
I have an answer for Azam, Rafique bhai, because we had these digitalist issues. If it is a Mobius type 2, our EP guy, Dr. Gurura, says that there is conduction system problem. Digitalist alone will not do the Mobius type 2. I have not checked it, but that was his answer.
Okay. So I have, I think, 4 ECGs, but so I'm changing the sequence because it is coincidence that Dr. Akanda's ECG and one of the ECG that I'm going to present have similarities. So let's start with this one. And I have the choices. If we could give the poll.
Starting the poll, sir.
That's good. I think B and C, I'll accept both, but if you become a little bit more particular, there is evidence of left atrial enlargement. One person said ventricular tachycardia, and the subsequent discussion will tell us why this is not ventricular tachycardia, but this is clear left bundle branch block. If you look in, there is P wave before each QRS complex. That means it is supraventricular rhythm. So that takes ventricular tachycardia out. If it were accelerated idioventricular rhythm, you would have seen AV dissociation. There is no AV dissociation in this case. Thank you. So next ECG, let me see. Okay, this one. So yeah, please wait, let them look at this thing and then go for the poll.
Okay, sir.
This is similar to the ECG that Professor Akanda showed, and I thought this will be interesting to discuss both of these.
So starting the poll now then.
Yeah.
You can start now.
Okay, so we are very equally divided.
Yes, sir.
56% said ventricular tachycardia, 44% said supraventricular tachycardia, left bundle branch block. So let's go over this thing. These are both choices. So so this is the ECG that I showed. There are a few things that we look at that Dr. Akanda mentioned, that precordial concordance. That means, give me 1 second. That means if the QRS complexes look all the same direction, if you look at V1 through V5, they look down, but V6 looks up. So it is not, if it was, yes, it would be VT, what Dr. Akanda's ECG was, but it was no. So we go for the next criteria, which is onset of the R to the nadir of S wave in any precordial lead more than 100 milliseconds. So what I decided, that I look at all these things and I thought that V5 is the widest. And so let's look at V5. So I took that V5 complex, and if you see that it is barely, it is not 100 milliseconds. This was the widest. So when you look at this ECG, look at carefully that if you can find that, and it helps distinguish. So the next, this was the answer is no. If it was yes, it would be VT, but no, the answer is no. Then we look at AV dissociation. Unfortunately, this ECG, it is almost impossible to say if there is any AV dissociation. As a matter of fact, if you think about it, if you look at lead V1 here, that there is something here, maybe a retrograde P wave, but I cannot say there is AV dissociation in this ECG. So that criteria is useless for this patient. So the answer is no. And then we look at morphology criteria. And the morphology criteria is, if it is right bundle type, it will be this. Let's forget about the right bundle type. We look at left bundle type in lead V1 and V6. In V1, if the initial R wave is more than 30 milliseconds, that is VT. If from the beginning of QRS to the deepest point of S wave more than 60 milliseconds, that is VT. And if there is a hump, that supports VT. So let's look at that. I'm going to look at this. So I have taken, V1 doesn't have an R wave, but V2 has R, so I have expanded it. If you look at the R wave, it is less than 20 milliseconds. Looks like just left bundle. And then from the beginning of the R wave to the deepest point of S wave is about 50 milliseconds. So you see, by all this, and there is no hump in any of this. So this is basically an SVT with aberrant conduction. So please remember this, we'll keep repeating this thing again and again. Even with all this, one of the things that you, Dr. Akanda said, and I am looking at here, that not all patients are going to fulfill all the criteria. And even after doing all this, there can be some overlap. And this patient actually responded to IV adenosine and converted to sinus. Even though it's a 75-year-old female, there are some. Okay, now this is one, my favorite ECG.
Rafique bhai, before you go to the next EKG, that
yes.
showed me. What about the, because we get problems with this EKG from the ER. They call for a STEMI. What is your comment on that?
Oh, that patient?
Yeah.
That patient was not having chest pain, came with palpitation only.
No, I'm saying they ER calls it Mike saying that how you guys will tackle.
This is the problem, knowing left bundle, this the criteria for VT has created more problem than itself. So this is a common problem in our emergency room also. Luckily, yeah. I am not an intervention person, so I don't have to wake up in the middle of the night to answer that question.
Yeah, no, but Do you? So I give you a couple of things on this. If they encountered this problem, particularly sometimes the ER asks too many times chest pain, and after 3 times having the same question, patient starts saying, "Okay, I have chest pain." But the question is that I don't. When there is, do you think that EKG there is LVH?
Oh, I had 12-beat ECG later on. With left bundle, it is very tough. Yeah. So
yeah,
this
so
one.
the few things, when there is a tachycardia, I tell them not to read overall. I control the rate and then repeat EKG, do echo imaging, and then go from there. So don't over.
Yeah, that patient actually after conversion had narrow QRS. So good news is that nobody answered that. There's a little bit left for X. Nobody said this is an abnormal ECG. So all those are good choices. If somebody says this is a normal ECG, I will accept it. Sinus rhythm with sinus arrhythmia, I will accept it. But I will also accept the best answer to be there is poor ROA progression from V1 to V4. And what is the significance of it? That's the different story. But I think it will be good that you all mention that finding when you see the poor ROA progression. This is the normal ECG basically. So next one, this is the ECG that the residents called me, and the patient was having sinus tachycardia. And if you look at the ECG report, I put the ECG report. Please carefully look at this ECG, and then I would like you to answer, and then we'll go over it. Decide what it is. Okay. So, I mean, I think we're not going to go into discussion because I have other ECGs. So I think these are all valid considerations. Sinus tachycardia with supraventricular premature beat with aberrant conduction, sinus tachycardia with ventricular premature beat. And I have doubt about A, because if you look at these wide QRS complexes, they are a little bit too far away to be aberrant conduction. Second, aberrant conduction more commonly right. So I think this is not aberrant conduction. These are ventricular premature beat. And then I'm going to come to the tachycardia part. So this was on the 10th of December, this last year. And this is the ECG criteria that we used for this. Whoever used it, you can see it, that we look at the position of the P wave, and let's make an assumption. This lead 2, this is the P wave, or in V1. And then if we look at the position of the P, if we cannot see the P wave, it's AVNRT. If we can see P wave immediately after the QRS complex, it's AVNRT or AVRT. And then, of course, depend on in the ST segment P wave. And we look at short RP or long RP. In this one, if you look at this, where I magnified this, RP is 240, PR is 200. So it is a long RP tachycardia. So this is either atrial tachycardia or sinus tachycardia, one or the other possibility. And depending on the morphology of the P wave, it will either say whether it's, it can also be atypical. So if you look at the P wave in 2, it's kind of funny looking. So the question will be, is it sinus tachycardia or atrial tachycardia, or is it some kind of atrial arrhythmia? So I'm going to go and show another ECG. This is on the 9th. Heart rate is still 132. And what I have done, I have put on the top, on the 10th, in the bottom is the 9th. heart rate is exactly same for 2 consecutive days. Now I am going to put my choice back again, and I'll want to see if the answer pattern changes. A patient whose heart rate has been 130 to 132 for 2 days in a row. Is it sinus tachycardia or is it 3 or 4? What do you think?
Restart the
Yes,
poll.
starting the poll.
Good. So this is better, but still 2% said sinus tachycardia. One of the things about sinus tachycardia, you cannot have a patient whose heart rate remains fixed 132, 130, basically it's the same heart rate for 2 consecutive days. Even if it stays for 2 hours, the same heart rate, it cannot be sinus tachycardia. So it is either an atrial tachycardia or atrial flutter with 2-to-1 conduction. So that was my diagnosis. And then I found another ECG on this patient. This is, let me see what the date was, on the 9th. If you look here, there is some variability in conduction here. And I try to see if I can find a P wave. And what I did, I expanded, you see this ECG, QRS, there is something here, something, and if I expanded it, you can see the flutter wave now. So, but again, in another place, I can see here the flutter wave. So the choices from that ECG, if we don't find it, it will be either atrial tachycardia or atrial flutter with 2-to-1 conduction, but not sinus tachycardia. And the patient ended up having electrical cardioversion after transesophageal echocardiogram and restored sinus rhythm. But this is something that, please remember that. So this one, I think this is the last ECG. Please look at it and then we'll talk about it. Okay. I would like our faculty to comment on this and this answer. So majority said multifocal atrial tachycardia. Some said sinus rhythm with runs of multifocal atrial tachycardia. And then few people said atrial fibrillation.
Yes, sir. I think, sir, excellent response from the participant. I think, sir, as because possibly there is no one to choose the atrial fibrillation, as because it is unlikely to be atrial fibrillation, as because we can see organized P waves, either same morphology or different morphology. So participants do not choose the atrial fibrillation. I think that this is the right, that is the rightly choice, sir. None of the students has choose the atrial fibrillation. Sir, sinus tachycardia with sinus arrhythmia, this is definitely one of the possibilities, but I am more in favor of the, sir, multifocal atrial tachycardia, as because in lead 2, I can see, sir, beat 1, there is a P wave before the QRS complex. The beat 2, there is a P wave of the different morphology. Beat 3, inverted P wave, but deeper. Beat 4, inverted P wave, but slightly shorter. And again, beat 5, the P wave is again positive. So there are multiple morphologies of the P wave, and there is also, sir, AV block, evidence of the AV block, I think. So I am in favor of the, sir, multifocal atrial tachycardia, inconsistent with our participant.
Okay. Anybody else, any comment? Okay.
Wadud?
The question is it pure multifocal atrial tachycardia or is there any sinus rhythm with runs of multifocal atrial tachycardia? So I'm going to, let's move on. I cut down the ECGs and I mark them. So I put the A as the atrial beat. I did not mark this one. This one, P, I considered sinus. Why? If you look in V1, it is biphasic and upright in lead 2. So I thought these P, marked P waves are the sinus beats. And then there is a P wave, A wave, atrial beat, negative. And I'm going to expand those things. So one of the things that people always talk about multifocal atrial tachycardia, people will look at different leads and call multifocal atrial. You cannot do that. You have to look at a single lead. And this is a very typical multifocal atrial tachycardia because this P wave is negative. This is biphasic. Again, a little bit more biphasic, and these are positive. Please, there are 4 different morphology of P wave in the setting of a sinus P wave. So this is basically sinus rhythm with runs of multifocal atrial tachycardia. I think I'm done. Thank you. That's good. Good answer. Unless anybody has any comment.
Rafique bhai, the last ECG looks like when there is sinus beat, then the RR interval also is very regular. When there is abnormal P wave, the RR interval also becomes irregular. So for the multifocal, we need to prove that 3 different morphology and RR also irregular, right? Because
yes.
then the later part will be unusual to have the timing sum that the RR is steady in the presence of multifocal. So the D is the best fit in the answer.
Yes, absolutely right. But I mean, that's
patient is COPD.
Patient is COPD.
This is like typical COPD patients.
Exactly. Yeah. Question would be what to do with these patients, right? I mean, people always ask me, these are the most difficult patients to treat because with COPD, you cannot give beta blockers. Best drug probably is calcium channel blocker. I mean, if they have hypertension, you can give calcium channel blocker and that works. But these are a really difficult patient. You cannot, these are not good candidates for ablation because the focus is a multiple location. So they're not ideal candidate for ablation. So the drug of choice is calcium channel blocker, and that works best.
Sir, whether ivabradine works here, sir? Ivabradine.
Okay. Question is ivabradine. If ivabradine would work, ivabradine works in the funny current, but the problem is the funny current is only associated with sinus activity. Funny current, if you remember the action potential, there is sinusoidal action potential of the sinus node, and the phase 4 is where the funny current is. And that funny current pertains only to the sinus. That's why ivabradine works only for sinus tachycardia. It doesn't work for atrial arrhythmias. I wish it would.
And the important thing is that to treat underlying COPD as well. And then if it is cardism, but diltiazem is good, Rafique bhai. But
yes,
if it is patient is on DIG, then avoid DIG.
Absolutely, absolutely.
Yeah.
Thank you.
Firoze.
Thank you, sir. We have got another ECG, ECG of the week. Today is
Firoze.
sir.
No, today there will be no ECG of the week.
Okay, sir. Then we are almost finished. Now, Professor Atahar Ali sir can make their concluding remarks of today's session. We must thank Professor Abdul Kader sir for his brilliant presentation and Rafique Ahmed sir for showing us some beautiful ECGs. Professor Atahar Ali sir for final comments.
Yes, sir. Actually, a very nice session today, as because Professor Abdul Kader Akanda has shown 2 ECG. That is actually really the real ECG in our daily practice, what we face every day. and actually Professor Kader is our teacher, examiner, and real clinician. So thank you, Professor Abdul Kader, for showing the nice ECG and introducing the excellent discussion. And we and also our participant has got good number of answer to the many of the questions that is asked frequently in the examination. And that was the Professor Abdul Kader that shown the two ECG. And finally, we are grateful to Rafique Ahmed sir, finally again showing the same thing and repeating the same thing, and we are getting every day some knowledge about the diagnosis of this ECG. Sir, we are waiting for your session every day. And lastly, I can see Professor Mohsin Hossain. Mohsin.
শুনছি স্যার
So there are some of our other faculties also today. That is Naharuma,
Give me 5 minutes.
Habiba Firdausi, Shaila Nabi. Mohsin Hossain.
জি স্যার
Any comment from today's session? Abdul Kader's presentation, excellent.
স্যারের প্রেজেন্টেশন ওয়াজ ভেরি এক্সেলেন্ট স্যার হ্যাঁ
Professor Abdul Chowdhury. Sir, our next Saturday, our presenter will be Anisul Awal.
Okay.
Sir, young faculty from Chittagong, sir, Dr. Anisul Awal.
So listen, I mean, I know Beximco sponsored this meeting, but I always appreciate Rivu's presence. I mean, middle of the night, she has nothing to do with this ECG business, but she is sitting there with a smiley face. I mean, we must thank her. All of us should thank her. She is a wonderful girl.
Thank you, Review. Thank you for helping us with this session. Before concluding the session, thank you everyone for this session, first session of the 2021, and Happy New Year also, to all of you. We'll meet next Saturday at 9 p.m. Till then, bye. Goodbye.
Happy New Year. Goodbye. Bye.
Happy New Year, sir.
New Year. Thank you so much. sir.
Bye-bye.
Thank you. That really
Thank you. Happy New Year, sir.
Thank you very much for inviting and tolerating my
And finally, it is the smile face of
চাপামারা
every
লেখা tolerate করার জন্য, কারণ without
excellent. মানে তুমি পরীক্ষার অর্ধেক কোশ্চেন আউট করে দিছো আজকে।
Practical জিনিসটা দেখাইছে স্যার।
অর্ধেক কোশ্চেন
lecture, sir.
বুঝছো? যে